Good morning. We're going to go ahead and get this final exam review taken care of. I've had some internet issues this morning. This is the second time I've restarted this review, so I'm hoping that this will be it. So let's go ahead and get started. Okay. So remember, we're going over here to our module 5, and we're going to pull up that 27-page final review. Okay, that's what we're looking for. This one right here. That's the one we're looking for, okay? Okay. This first part is about medical legal stuff, which is your chapter 3. Very important because it shows us, how we are walking through, just the rules and regulations and things like that we have to work within when we're an EMT and when we're trying to provide care. Okay, so your standard of care. This is the manner in which the EMT must act and behave. So these are your responsibilities, and well, actually not responsibilities. That's going to be your scope of practice. This is going to be how you are supposed to behave, how you're supposed to handle yourself. And the two questions are always, did you provide the right assessment and care, and did you perform the assessment and care properly? Okay, so did you do what you were supposed to do, right? You know what you're supposed to do. You have these protocols, you have these guidelines, and did you do them? That's really your standard of care. Your scope of practice is the actions and care that EMTs are allowed to perform by the state in which they work, what you are legally allowed to do or authorized to do by state policies and regulations, and also by that medical director. Okay, remember, the medical director is the one who provides medical oversight to an EMS provider. But the scope of practice is, the skills and the medications and what can you do, right? Standard of care is how you're supposed to act. Scope of practice is what can you do. Libel and slander are kind of two sides of the same coin because it all has to do with false and damaging information being communicated about a person. Libel, however, is when it is communicated in writing. Slander is when it is communicated verbally by the spoken word. And a lot of times we see this during elections, political elections, people are, talking bad about their opponent. Or, if you get mail, that and those political flyers that talk about, you don't want to vote for this person because they do this, X, Y, and Z. So the stuff you get in your mail, that's libel because it is written. And then the stuff that you hear is slander. Okay, that false and damaging information about about a person. Now, negligence is the failure to provide the same care that a person with similar training would provide. So in the state of Texas, anyone who goes through, an EMT basic course and gets their certification, they all have pretty much the same scope of practice and all that good stuff, right? So, if you get on scene and you are presented with a patient and you don't do what your training has prepared you for, right? So you don't care appropriately for that patient, or you do something and the patient is injured, or you don't do something and the patient is injured or harmed because of your lack of actions, then that can be considered negligence, okay? And there are 4 very specific things about negligence that comes into play in order for someone to be found found negligent, okay? And the first one is you had to have had a duty to act. The second is there was a breach of that duty. The third is that a patient suffered harm or injury. And the fourth, which sometimes is the hardest one to prove, but the fourth is the injury was resulting from that breach of duty. Okay. So, and that's what we call proximate cause. So all four of those things have to be in place in order for someone to be found negligent, or think of the word, when you're found to be negligent. Okay. And then have legal, repercussions from that. Now, abandonment is different from negligence. Okay. Abandonment is a completely separate thing. This is the unilateral termination of a patient's care by the EMT without the patient's consent and without making provisions for transferring care to another medical professional that's capable of meeting the needs of that patient. So what does that mean? That means that you would have, I don't know what this is. Close that. That means that if you're no longer able to take care of this person, and you just leave them, right? And you don't find another EMT, or you find someone with a higher level of certification, right? Because it has to be a unilateral transfer of care. So abandonment is that unilateral termination of care, right? So think of it this way. When we take a patient to the ER and we transfer care to the staff there, right? We normally transfer care over to a nurse or a paramedic or someone of equal or higher level of training than us, right? Because if I didn't do that, if I just came in and left them in the hallway, put them on a hallway bed and left without actually giving a verbal report and ensuring that the patient's needs are going to be met, that's abandonment, right? Or if maybe I'm in the room, maybe they tell me to go to room 32, and I go to room 32 and I'm moving the patient over and getting them all situated and everything, and registration comes in, and they come in because they need to go ahead and get the person in the computer. So they get the patient's name and their birthday and some of their demographics and things like that. But the nurse never comes in, or the paramedic never comes in to take a report from you. And all you do is give the information to registration, who is not certified by any means medically, right? And then you leave. That is considered abandonment because you didn't have a transfer of this person's care to another medical professional that's capable of meeting the needs of that person. EMTALA, which we talked about EMTALA, on our Mod 5 review, and we've talked about quite a few of these things on our Mod 5 review, which is okay. But EMTALA is the Emergency Medical Treatment and Active Labor Act. That's what it stands for. These are the federal regulations that ensure access to emergency care regardless of the patient's ability to pay. So what does that mean to you? That means that, when we get called, when someone calls 911, we don't ask for payment up front before we care for them. We don't. We'll ask if they have insurance and stuff like that, and we'll put it in their patient chart. So all that stuff will be billed afterwards, but we're not just, barring the doors of the ambulance saying, you can't come in, we're not going to help you until you pay us, right? That kind of thing. So EMTALA basically says, it doesn't matter a patient's financial status or their ability to pay, they will receive life-saving treatment if requested, right? So if you have a patient that we take to the hospital, okay, and there are some hospitals that are considered private hospitals, and there's some that are county hospitals, okay, and so and it really doesn't matter what the insurance status of the patient is, but for those private hospitals, they will stabilize that patient, right? It's their duty to stabilize, take care of that patient, take care of any kind of life-saving treatments that may need to occur, stabilize them before they transfer them to another facility. Okay, so again, you don't have someone standing at the doors of the ER saying, nope, you can't come in until you pay. That's not how this works, right? So EMTALA it protects the patient for that. But it also makes sure that if a patient is being transferred from one facility to the next, that the hospital ensures that the EMS providers that are transferring the person, that are actually taking care of that person en route from hospital A to hospital B, is capable of meeting the needs of them, right? So that's what EMTALA is. Now, assault and battery again are very, very similar to libel and slander in that they go together. Okay. Assault and battery is the unlawful or unlawfully placing a patient in fear of bodily harm. So like an example would be, threatening to restrain the patient if that doesn't want to be transported. I'm going to tie you down if you don't, stuff like that, right? That is assault. And battery is the physical act of unlawfully touching a patient or providing emergency care without their consent, right? So assault is more like the threat of something and putting that person in fear. And then battery is actually when you physically touch a patient without their consent or provide care without their consent. Okay. So before we go on to the next page, who provides medical oversight to EMS providers? Okay. And that goes along with what we were talking about with scope of practice. So who provides medical oversight? And that's going to be your medical director. Okay. And just as a quick review of online medical direction versus offline medical direction. And I know in class, I showed you guys some protocols and stuff like that you can find on the internet. You can Google all kinds of protocols, but offline medical direction are your standing orders or your protocols, right? Those are your guidelines that have already been outlined for you. For if you have a patient complaining of this is what you can do. Okay. So you have offline medical direction like that. Now, online medical control would be where you have like a real-time conversation with a physician about a patient, and you're getting orders real time, whether it's in person or over the phone, about how to care for this person. So you have differences in that offline medical direction versus your online medical direction. Okay. But your medical director is the one who ultimately provides medical oversight to you because you're working underneath their license. Okay. So looking at this second page, the first thing on here, we've got that Good Samaritan law. And remember that Good Samaritan law is really nice to have because it protects a person who is not being paid for his or her services. So you guys would be off duty. It protects you from liability for acts performed in good faith. Okay. Except for cases of gross negligence. All right. And gross negligence would be, you doing something completely outside of your scope of practice, that you have absolutely no training on, no nothing, and then you would most likely get in some kind of trouble for that, right? But the Good Samaritan law is really nice because if you have the good intention of helping that person and you're not on duty, then you're pretty much covered. These different kinds of consents, we've got implied, expressed, and voluntary. These are the three big ones we're going to talk about. Implied consent is when a patient is unconscious or incapable of making an informed decision. The law assumes that the patient or any other reasonable person would consent to care and transport, right? Most of the time, this is used in those life-threatening situations, like when a patient is unconscious if the patient is unconscious, then they're in a life-threatening situation, right? Because they can't control their airway. But if they are altered or something else is going on, then we operate underneath implied consent that they or someone else would want us to care for that person. Also, when we're caring for minors, that also goes underneath implied consent. Okay, because a minor, remember, is someone who cannot consent to their own care. They're not an adult, so they can't consent to their own care. So when we care for them, it's done under the blanket term of implied consent. Now, expressed consent is given when the patient acknowledges that he or she wants you to provide care, whether it's by a verbal or nonverbal communication, but it is expressed to you by the patient that they acknowledge that they want you to provide care. They are giving you consent to provide care. Okay. Obviously, the patient has to be mentally competent in order to make that decision. Okay. So express consent is when they tell you through verbal or nonverbal means, yep, come on in, help me, that kind of stuff, right? I want you to help me. Now, involuntary consent is common for patients who are mentally ill or experiencing a behavioral crisis. And this consent is normally granted by the courts or by law enforcement if the patient is in their custody. So it doesn't matter if this person is alert and oriented and can answer your questions and all that kind of stuff. Something is in play. Most of the time it's a mental illness or a psych issue or something like that. Something is in play where that person is not able to make those decisions for themselves, right? And at this time, that involuntary consent is granted by the court to take care of this person, okay? All right. So who cannot give consent? Who cannot make medical decisions, and what are the exceptions? So minors are the big one. We talk about minors a lot. Remember that falls underneath implied consent. If the patient is under 18 years old, 18 is the legal age for an adult when you're talking about medical stuff, okay? So if the patient is under 18 years old, if the patient is in the custody of police, okay, like the apprehension by a police officer without a warrant, that APOWW, okay? If they are in the custody of the police or the police have taken custody of them for their health, then they cannot make medical decisions. And this one is where, you know, when they've got suicidal ideations or they've done something to act upon those suicidal ideations, right? So that person cannot make decisions for themselves. When a patient's mental status is altered, okay, because if they're altered, then again, they're not competent, they're not medically competent, able to make decisions for themselves, and so we would operate underneath implied consent. And then the exceptions to these rules, a lot of these exceptions deal with minors. There's a couple. The first one is going to be your emancipated minor. So an emancipated minor is going to be a person who's under the age of 18, but has been deemed an adult by the courts, by the court system. Okay, so they are legally considered an adult, even though their age is underneath the age of 18. And most of the time, there's something going on in their social, social circle, in their family, their personal lives and stuff like that, to where the courts have had to get involved, and they are considered an adult at this time. That emancipated minor, when you ask them how old they are, they should have all the documentation that you need, okay? Because they understand that they're not an adult by age yet, and so they're not going to be able to make those decisions if they don't show the documentation that they are legally an adult by emancipation, okay? So emancipated minors. Another exception to the rule would be minors that are members of the armed forces. Okay, once you sign up and are a part of the armed forces, then you are considered an adult. So if you're less than 18 and your parents or caregivers or guardians have given the approval for you to be a part of the armed forces, then you are now an adult. Okay. Another exception to the rule is if those minors are parents. Okay. Now this is going to sound really weird, but a minor, so someone under the age of 18, if they're a parent, they can make decisions about their child, but they cannot make decisions about themselves. I know that sounds weird, but that's the exception. What about that minor that is pregnant? That minor under the age of 18 that is pregnant, that person can make decisions about their pregnancy, okay, about pregnancy-related issues, but they cannot make decisions about non-pregnancy related issues. Okay, so for example, I'll give you an example. You have someone who maybe they're 16 and they're pregnant, and she's having abdominal pain or vaginal bleeding or something like that. Then that patient, although they are underneath the age of 18, they can make decisions regarding their pregnancy related emergencies. But let's say you get called for maybe she fell and broke her wrist or something like that, right? And it's not pregnancy related. At that point, she cannot make decisions for herself, okay? So it's a little, gets a little gray area right there. And then another exception to the rule is are going to be minors that are married. Okay. So again, if you're underneath the age of 18 and you're married, legally, the marriage itself has to be approved by the parents and by the guardians. So they are considered legally adults once they're married. Okay. So there's a couple exceptions to some of the rules. And sometimes it gets, you just have to make sure that you ask the appropriate questions when you get on scene to make sure that you're operating underneath, the rules and regulations appropriately of what we're allowed to do. So moving on into assessment and vital signs. This is straight from your Mod 1. Excuse me, straight from your Mod 1 and things that we've been practicing this entire semester, right? This entire course. So the question is, write in order the primary assessment or the life threats of the patient, why they are in that particular order. Okay, so the first thing that we look at, and this is going to be after your scene size up, right? So this is your primary assessment. The first thing that we look at is your patient's level of consciousness. Okay, what's their neurologic status? Because we're thinking, is the brain getting enough oxygen that it needs, right? And remember, unconscious patients cannot control their own airway. So what's their level of consciousness? And then we look at airway, breathing, circulation. Is their airway patent? Is it open? Do I need to suction it? Things like that. What's their breathing status? Are they breathing on their own? Are they breathing adequately, right? And then circulation, what's their skin look like? What's their pulses? What's their cap refill? All of that. Now, if you have a trauma patient, then remember we throw in X ABCs. It's not just ABCs, we throw in X ABCs, and that X stands for exsanguination. So we have to deal with any uncontrolled bleeding before we address the airway. But if it's a medical patient, then airway comes first. Okay. What are some key words for issues that need to be addressed in ABCs? What do you look for in breathing? All that good stuff. So again, some key words for airway, especially if you're looking at, like reading it in a question form. If the airway is patent, you're looking for, that's a key word because patent means it's open, right? If there's an obstruction, okay, a partial obstruction versus a full obstruction. Remember, if there's a full obstruction and they're not getting any air, and pulse oxes are low and they're getting cyanotic and they can't talk and all that good stuff, then you're going to have to use your relief of choking techniques, right? Whether it's the abdominal thrust for the adult and the child or the back blows and chest thrust for the infant. But if it's a partial obstruction, then you have a decision to make, right? Are they getting enough air? Are they talking to you? Is this something that I just monitor and transport, or do I need to do some of my actions? Okay. Other words for the airway: noisy airway, gurgling respirations, snoring respirations, right? When we hear snoring respirations, it means that we need to get the tongue out of the way, right? Simple head tilt chin lift maneuver. If we hear gurgling or noisy respirations, then we may need to suction that patient and make sure that those secretions are out of the way because the airway is not patent, right? So we need for it to be open and clear in order for the air to get through. Breathing, a couple questions about breathing. Obviously, we want it to be present, and we want it to be adequate. So I want you guys to look at the rate. If you're given a set of vital signs, look at the rate. What's your respiratory rate? For an adult, we want 12 to 20. If it's less than 12, then you have a problem, right? What's their tidal volume also? You want to look at their tidal volume. Are they getting enough oxygen? Are they moving enough air per breath, right? Because if they're not, then you're going to have to assist their ventilations and help them. So look at their tidal volume. And a couple key words would be like minimal chest rise and fall, shallow breathing, because the tidal volume is where we're looking at their chest rise and fall. We're seeing the chest open and expand with each breath. Okay. And then of course, if you have signs of hypoxia, if your patient is cyanotic, which that deals a little bit more with skin, but altered mental status, of course, because if they're altered, then it could possibly be hypoxia as well. So signs of hypoxia can kind of come in all forms, right? Altered mental status, cyanosis to the skin, They can be very, very agitated. Someone who is hypoxic is going to be very agitated, not going to be able to sit still, and because their tissues and their body is hypoxic. Couple keywords for circulation. We're looking at mental status, right? Again, if their mental status is altered, then that means the blood isn't getting up to their brain and it isn't delivering that oxygen up to their brain, right? Their pulse. First off, I want to know, where did you find that pulse? Okay, because if they have good, strong carotid pulses, but they have absent radial pulses, then that means we have a circulation issue, right? So where was the location of the pulse? What's the rate of the pulse? And what's the strength of the pulse? You have strong versus weak, right? Present versus absent. And then the rate is important as well. The skin condition. What's the temperature? Are they warm or are they cool? What's the color, right? Are they pale? Are they ashen? Are they mottled? Are they cyanotic? A lot of things can be seen with the skin. And then again, check your cap refill, right? So check your cap refill because we want all of our patients to be less than 2 seconds. The normal breathing rate for a patient, we've got 12 to 20 breaths per minute for your adults, and we'll go over some more in the next question about your pediatrics, okay? But 12 to 20 is for your adults. The goal of their pulse ox, that SpO2, the goal is to always have a pulse ox above 94%, okay? Their tidal volume, you want their tidal volume to be adequate, right? And remember, the tidal volume is the amount of air moved in or out during a single breath. We want it to be adequate. The average tidal volume for an adult male is about 500 milliliters or half a liter of air. And the average tidal volume for your adult female is about 450 milliliters, a little bit less than that. So why is that important? It just tells you that when we're bagging the patient, when we're utilizing that BVM and assisting ventilations, that, remember, you're only bagging until you see chest rise and fall, right? We're squeezing that bag to see chest rise and fall because the bag itself has more volume than what our lungs can handle. The minute tidal volume formula, right? Minute volume, MV, equals your tidal volume, or your TV, times your respiratory rate, correct? So minute volume is tidal volume times respiratory rate. So just kind of keep that in mind when you're looking at, the rates are dropping and tidal volume's dropping, then that means we're not moving enough air. When you're dealing with pediatrics, how do we treat each vital sign when it's outside of its normal limits? So first and foremost, let's think about what we've got as normal, right? And I have these written down somewhere. Hang on. If you want to check your normal ranges of your vital signs for all age groups, then I highly recommend you go back to your chapter 10. And if you're looking at table 10-6, that's going to deal with heart rate. If you look at table 10-4, that deals with the respiratory rate. And table 10-7 is going to deal with your blood pressures, okay? So this one is asking about heart rate when it's outside of its normal. So with pediatrics, when the heart rate is less than 60 beats per minute, you have to ventilate your patient, okay? Because remember, pediatrics are normally, they have higher heart rates than an adult. Normal heart rate for an adult is 60 to 100, and your kiddos are going to be higher than that. So looking specifically at this question, if the heart rate is less than 60 beats per minute, which is the lowest of what's normal for an adult, then you have to ventilate that pediatric patient. You have to provide positive pressure ventilations and bag that patient. One of the things we always say is hypoxia is the leading cause of cardiac arrest, or the leading cause of bradycardia, and then ultimately cardiac arrest in your patients. So if they're hypoxic, we need to ventilate them. So if their heart rate is less than 60 beats per minute, we assume they're hypoxic, and so we ventilate. We ventilate for about 30 seconds or so, right? Give it a little bit of time, but not too much. And then we're going to reassess the pulse. And if the pulse is still less than 60 beats per minute, despite that adequate ventilation, then you must start CPR. You just got to start CPR because their heart rate is not high enough. Okay. The blood pressure, let me go ahead and pull up that, let's see, pediatric BP formula. All right, I'm gonna share this. So we talked about this in mod 4, your systolic blood pressure for your pediatric patients. This is what you want their systolic blood pressure to be. You want it to be 90 plus 2 times their years in age. And this is a really great formula to use for kiddos that are between the ages of 1 and 10. Okay, 1 and 10. But again, take a look at that table 10-7 for all your different blood pressures. That'll really help. Okay, we go by that systolic. So if it's less than that, then it's most likely they're not perfusing very well, right? Okay. Let's go back here. So how do we treat it if they have a low blood pressure? Well, that means that their skin is going to be dusky and pale. Cap refill is going to be delayed. So keep them warm, provide high flow O2. You may need to position them, in Trendelenburg if they're big enough to do that, and then rapid transport, right? Okay. But also try to figure out why their blood pressure is so low. Is this, because normally that means shock, right? Is this hypovolemia? Are they bleeding? Do I need to treat the bleeding? Is this sepsis? Do I need to identify the infection, get them to the hospital so they can get antibiotics? Is this anaphylaxis? Do I need to give them epi? What do I need to do? Can I manage that blood pressure? Temperature, this is kind of pretty straightforward, but obviously if they have a low temperature, if they're cold, then warm them up, right? First thing is to get them out of the cold environment, and then you can actively warm them up with hot packs and things like that. If their temperature is too high, so if they're hyperthermic, then again, get them out of the heat, cool them off. You can passively cool them off just by removal of excessive clothing and things like that. You can also turn on the AC higher in the back of your ambulance. You can give them cold packs, ice, things like that, but address those temperature abnormalities. And then the respiratory rate. So again, if you take a look at table 10-4 in your chapter 10, that will deal with the respiratory rate. Now, the respiratory rates are inherently higher than adults. Okay, so the heart rate is higher than adults, the blood pressure is lower than adults, and the respiratory rate is higher than adults, okay, when we're looking at normal vital signs. But if that respiratory rate is too low for that patient, then you have to assist their ventilations, right? And so that deals with inadequate breathing, respiratory failure, things like that. You have to assist their ventilations, okay? What's their tidal volume? What's their oxygenation? Making sure that they're adequately breathing. Identify the order in which you treat the following vital signs. So we've got 3 things listed here. Okay, and I want you to think about, your ABCs. If this was a trauma patient, we would be thinking X ABCs. Okay, but I've got a blood pressure of 88/46. The assumption is this is an adult. Okay, we have a respiratory rate of 6 respirations per minute, and then our airway has gurgling respirations. So thinking about ABCs, I'm going to deal with that gurgling respirations first. I'm going to suction that. Then I'm going to deal with the breathing, and then I will address the blood pressure. Okay, so C is 1, B is 2, 3 is A. Okay, that's the order in which you treat them, because airway always comes first with those medical patients. Orthostatic vital signs. So orthostatic vital signs, this is a way for us to assess a patient's volume when we're taking vital signs in different positions, okay? So the vital signs will be obtained while the patient is lying supine, and then you can move them to a sitting position and get another set of vitals, and then move them to a standing position and get another set of vitals, okay? If you can't do the sitting, then we're at least looking at supine versus standing, okay? And, sorry, hang on just a second. Sorry. Okay. So those vital signs are obtained while the patient is lying supine and then in standing. So you want to get blood pressure and you want to get heart rate. If they are positive, if they have a positive orthostatic, if they have positive orthostatic vital signs, or what we call a positive tilt test, right? That's kind of just another term you might hear is a tilt test. Then that means that their blood pressure and pulse changed from one position to the next, okay? For example, their heart rate going from supine to standing, if their heart rate increases of at least 10 beats per minute from supine to standing, then that's a positive tilt test. Or if their blood pressure has decreased by 20 or more points, they're systolic, from going from supine to standing, then that is a positive tilt test. Also, if your patient starts to experience lightheadedness or dizziness and they can't continue standing, then that's another sign of being of that positive tilt test. And this just means that they're fluid depleted. They have volume issues, right? Whether it's from dehydration or blood loss or something like that. Most of the time I'm going to do this for a patient that I suspect dehydration. Just get a set of vitals while they're sitting down or laying supine, and then try and stand them up and just see what's going on. You could, if your patient, if you really think this is going on, then just feel their radial pulse, right? Feel their radial pulse. Feel it when they're sitting down, laying down. Stand them up. If it starts, bumping along a lot faster, there's your positive tilt test right there. Okay. And again, if your patient is experiencing any kind of lightheadedness or dizziness upon standing, that's a positive sign of fluid depletion. Okay. And that will help us when we're just trying to figure out, what's going on with our patient. This chronological order of treatment of your life threats. Let's see what we've got here. We've got circulation, obtain vitals, breathing, sample, and airway. So this is going through your patient assessment, right? And just the sequential order of your patient assessment. So patient assessment, we do scene size up, then we do primary assessment, secondary assessment, and then reassessment. Okay. So if I was going by the book, by my skills sheet, then obviously airway would be first. Breathing is second, circulation is third. That's pretty simple, right? We really drill in that ABCs for all you guys. So ABCs, airway first, breathing second, circulation third. Sample is fourth as we start to ask our questions, and then vital signs is going to be fifth. Now, in reality, we're most likely obtaining vitals while we ask our sample questions, right? But definitely ABCs always comes first. This next question is talking about GCS. Very, very, very important that you guys understand and know how to calculate your GCS, okay? GCS, remember, is that Glasgow coma scale. This is different from AVPU. AVPU, that alert, verbal, painful, and unresponsive. AVPU is a very generalized way to look at a patient's level of consciousness and responsiveness. But GCS, the Glasgow coma scale, is much more detailed, right? So it allows us to really kind of dig in and get the detail of how your patient is responding to you. So your Glasgow coma scale is, let me find a good one. This one's good. So on your review, we have it broken down into eyes, verbal, and then motor. Okay, because those are the three different sections of your Glasgow coma scale. Okay, and this is how does your patient respond. So the eyes, when you walk in and give them some kind of, remember, alert, verbal, painful, or unresponsive, that is their level of responsiveness, and this is how they respond. So eyes, 4, 3, 2, 1. They either spontaneously open their eyes or they open their eyes to speech, to some verbal stimulus. They open their eyes to a painful stimulus, or there's no response, right? They don't open their eyes at all, okay? Speech there's 5 things in speech. There's 4 in eyes, there's 5 in speech, and there's 6 in your motor. So your lowest GCS that you can get for a patient is 3, and your highest is 15, okay? So when you have a patient who's alert-oriented, responding appropriately, and everything's good, they have a GCS of 15, okay? Now, the verbal or the speech section of your Glasgow Coma Scale, the highest is alert and oriented. Then you would rate them a 4 if they were confused. The rating of a 3 deals with inappropriate responses, like they're able to speak clearly to you, but the words that they're saying are not appropriate for the questions that you asked, right? So the difference between confused would be, if you ask somebody, what day of the week is it? And they say it's Friday when it's really Monday or something like that. Or if you give them, can you tell me what year it is? And they say it's 1995 instead of 2025, right? So it's confused, but it's still basically on the same topic. Now, inappropriate responses is when, can you tell me what year it is? And they say trees and butterflies or something like that, something that is totally inappropriate for the question that you asked, okay? Number 2 is going to be your incomprehensible sounds, where they're not able to form any words. They're moaning, they're grunting at you, just kind of incomprehensible sounds. They're not actually forming words. And then 1 is going to be no response at all. Okay, so no response. Now your motor has 6 things. Okay. This is how do they physically respond to you with their actions, okay? So number 6 is obeying commands. So that's good, right? We want them to be able to obey commands. 5 would be localizes pain. So that would be if you, if you did a glucose test on their finger, right? And they pulled their finger away from you, or they pulled their hand away from you, and they said, ow, then that's localizing pain, localizing where the pain is coming from, okay? Withdrawing from pain is if they just kind of tried, they're not necessarily localizing the fact that you're pricking their finger, but they're withdrawing their body from the direction of the pain. Okay, so if they were not very responsive to you and you got a blood sugar, because that's actually a really good assessment for someone who's altered or not responsive, right? And they didn't move their hand away, but maybe they just kind of like rolled their body or tried to move, their body away from you because it hurts. So they're withdrawing from the painful stimulus. 3 and 2, this is your decorticate posturing and your decerebrate posturing. Number 3, with decorticate posturing, that's also known as abnormal flexion. And 2 is your abnormal extension with your decerebrate posturing. And then 1 is going to be your no response. Okay, so what is the Glasgow Coma Scale for your patient? And like I said, I'm just telling you, you need to know what those are and how to calculate them. All right. What's the differences in bradycardia for your adults versus pediatrics? What's the treatment? So we kind of talked about this already with the pediatrics, but bradycardia for adults, remember, this may be normal, okay? Anytime you get something outside of what is considered book normal for your patients, whether it's respiratory rate or glucose or heart rates or blood pressures, anything that you learned that it should be between this and this, but it's not, then I always want you to follow it up with a question with the patient. Is this normal for you? Okay, because you could have some adult patients where bradycardia is somewhat normal for them. Okay, so get your sample history, assess your patients further. But if it's not normal for them, then I want you to, put them on high flow O2. Obviously, if they don't have pulses at all, then we're starting CPR and all that good stuff. But for your pediatrics, bradycardia is never, never, never normal in pediatrics, right? So just like we mentioned earlier in this review, if their heart rate is less than 60, you must provide positive pressure ventilations. You have to bag that patient and assist their ventilations to make sure because you remember hypoxia is the leading cause of bradycardia. So if you ventilate them for approximately 30 seconds and they don't respond well, and we're talking about their heart rate doesn't increase, then you start CPR. Okay, your acronym, DCAP BTLS. Remember, this is for our focused head-to-toe assessment, right? Your rapid head-to-toe assessment on a trauma patient, we're looking for life threats. Your focused head-to-toe, this is when we're going in and we're checking the eyes and checking the ears and checking the throat for tracheal deviation and JVD, and we're feeling for crepitus and going all the way down to all of our extremities and pelvis and all that good stuff, right? We're doing that focused assessment, and we're looking for any additional injuries in the form of DCAP BTLS. The D stands for deformities. This is going to be your misshapen body parts, right? Deformities. C is contusions. This is your bruising. When they have that collection of blood underneath the surface of the skin, you're going to see the discolored skin with that bruising. A stands for abrasions. Abrasions, remember, are it's damage to the skin from like a scraping or a rubbing. Normally, an abrasion is just the couple most outer layers of the skin. It's a very superficial injury, so it's not very deep. P is your punctures and your penetrations. Okay, sorry, I was looking at something. P is punctures and penetrations. This is a small penetration through the skin into the soft tissue, right? B stands for burns. Redness, blisters, white areas of the skin. We'll talk about all the different kinds of burns later on in this exam review. T is tenderness, pain when the area is palpated, right? Now it can be, you can have spontaneous tenderness, right? Or pain, spontaneous pain. I don't have to touch it, but you have to palpate your patients because it may not hurt until there's palpation. And if you never touch your patient, then you're never going to find it, right? L stands for lacerations, right? Lacerations. And these guys are deep cuts into the skin. Okay, it's not superficial, it's fairly deep. And S is your swelling, raised enlarged area of soft tissue on the surface of the body, right? Do you have swelling around a joint or around an injury for a long bone or something like that? Okay. So make sure you're good with your DCAP BTLS. Signs versus symptoms. Remember, signs and symptoms, this is part of our sample, right? So, and we don't ask our patients, ma'am, what's your signs and symptoms, right? We ask them what's going on today, and they're going to talk to us and tell us what's bothering them. And when they talk to us, they're giving us their symptoms, right? But what we see on our own is their signs. So signs is going to be what you see, maybe what you hear, something that you figure out from the patient just by looking at them, right? And a symptom is what the patient tells you. So a couple examples here. A sign would be like retractions, right? That accessory muscle use. Deformities, contusions, swelling, bleeding, anything like that. And maybe you do a fast exam and you find weakness in some of their extremities, right? That's a sign. Diaphoresis, that's a sign, right? Symptoms, remember, this is something I can't see and I don't know unless the patient tells me. That's going to be like dizziness or a headache or nausea, because I can't see nausea. I can't see a headache, right? I can see unequal pupils, but I can't see the pain of the headache, right? So that's the difference between signs and symptoms, which is why it's so important that we ask, what's going on today, right? Is there anything else that's bothering you? Do you have any pain anywhere? And we ask all of our assessment questions. Stimulants versus depressants. This is, we actually go over this twice in this review. It's not a big deal. But your stimulants, these are substances that stimulate the sympathetic nervous system. okay? They stimulate the sympathetic nervous system. And your sympathetic nervous system, remember, is your fight or flight. So you will see anxiety, diaphoresis, dilated pupils, increased heart rate, increased blood pressure, increased respiratory rate, increased body temperature, things like that. And some examples of stimulants would be like cocaine, methamphetamine, PCP, ecstasy, and caffeine. Okay. Now, depressants, these are central nervous system depressants. So they will decrease activity, decrease excitement, and decrease the level of consciousness, right? And cause altered level of consciousness. Your patients will have respiratory depression, the inability to control their airway because their tongue relaxes. Obviously, they're going to have altered mental status, and we know all the problems that come with altered mental status, okay? Drowsiness, we could have some seizures that actually occur from these, hallucinations, things like that. And some specific examples of depressants is going to be your marijuana, your K2, alcohol, ketamine, and date rape drugs. Okay, so just make sure you know what happens in the body when you have a stimulant versus a depressant, and things to look for. So we just talked about sympathetic versus parasympathetic nervous system. So make sure you know the difference between these two, right? Your sympathetic nervous system, like I said before, that's your fight or flight. This is the thing that gets you going, right? We got to survive. So it's going to increase all that stuff, right? It's going to cause increase in heart rate. It increases the force of the heartbeat. So you feel your heart pounding in your chest. It's going to vasoconstrict, right? Cause vasoconstriction. It's going to cause bronchodilation. It's going to cause diaphoresis. You're going to be sweating. You'll have dilated pupils. Your skin is going to be cool and clammy, okay? But this is that fight or flight, because that epinephrine is released from the adrenal gland in order for us to either run for our lives or fight for our lives. The parasympathetic nervous system is the opposite, okay? It's the other side of the coin. This is our feed and breed or rest and digest. This will decrease the heart rate, decrease the contractile force of the heart rate, right? I mean, we're just kind of relaxed, okay? I'm not keyed up. I'm just relaxed here. Pupils will constrict, okay? Digestive, things will kind of kick into gear, right? And it's going to help return the body to its resting state. So make sure you're good with what happens when each of those nervous systems are activated. Let's look at some respiratory stuff. So we've been talking about respiratory distress, respiratory failure. We've been talking about this since literally like day 2 or 3, right, of the class, because this is all about your life threats, your airway, your breathing, right? Okay, circulation is going to be shock, and which we'll go over in just a minute, BLS, all that stuff. But respiratory distress versus respiratory failure, it is absolutely imperative that you know this stuff, because if you don't recognize when your patient is in respiratory failure, then you're not going to care for them appropriately, okay? So respiratory distress. This is when the patient has a problem. They have shortness of breath. There's something bothering them. They have shortness of breath and they're working harder to breathe. But despite that, they're still getting enough oxygen to their body and into their cells, okay? You will see a normal mental status. You will see skin that is not cyanotic. They might be a little pale, but they're not cyanotic. And your patient's going to have a good respiratory rate and adequate tidal volume, okay? Now, you might see accessory muscle use. You might hear abnormal lung sounds like wheezing or stridor or something like that. But remember, that's just a sign that there's a problem. They're only in distress because I see a good mental status, I see skin that is not cyanotic, and I see a good respiratory rate and good tidal volume. Now, your patient will progress into respiratory failure if that problem is not fixed, right, and they're going to start to get tired and they progress into respiratory failure, and I know that they're in failure because now they don't have a good mental status, right? Now their mental status is altered. Now their respiratory rate or their tidal volume has dropped because they're not able to maintain their minute volume, and now their skin is cyanotic, okay? So respiratory failure is when we don't have enough oxygen in for ourselves and for our body. And the only thing that we can do for respiratory failure to adequately treat respiratory failure is to provide positive pressure ventilations with that BVM. Okay. Respiratory distress, I still have all kinds of options, right? I can place that CHF patient, I can put them on CPAP, or if they're in COPD with emphysema, and they have that alveolar collapse, then I can put them on CPAP. I can give them albuterol, right, for their wheezing. I can put them on a non-rebreather for oxygen. I can do all kinds of stuff for them, but I don't have to bag them yet. That's what respiratory failure is. I'm having to bag my patients and provide positive pressure ventilations in respiratory failure. Okay? If I don't do that, if I don't bag them, then they will progress into respiratory arrest. Okay? They may still progress into respiratory arrest depending upon what the cause is, right? Respiratory arrest means that my patient is not breathing at all. So they are apneic, right? And of course, you're absolutely going to see cyanosis at that time. Their respiratory rate is going to be absent, right? They're going to have no chest rise and fall, no tidal volume, because they're not breathing at all. Now, they still have a pulse, okay? So respiratory arrest means they still have pulses, but they're not breathing. Cardiac arrest means they have no pulse and are not breathing, okay? So make sure you know the difference between these, and then how do we, how do we treat them, okay? This basically is the same thing we just talked about. Adequate breathing. Adequate breathing is someone who is breathing appropriately enough that we're getting enough oxygen, right? So the signs and symptoms for an adult, the rate's going to be 12 to 20 with the regular pattern of in and out. Okay, the depth is going to have good, equal chest rise and fall with adequate tidal volume, and the pulse ox is going to be above, 94%, right? If we have inadequate breathing in respiratory failure, then that means that our rate is going to be less than 12, right? Or it might be over 20 with an inadequate tidal volume, right? So it's not only the rate, it can be the rate or the tidal volume. The depth, of course, is going to be shallow, inadequate, minimal chest rise and fall. And then the pulse ox, if it's less than 94%, but specifically less than 90, especially if they're already on oxygen. So if I have a patient who's on a non-rebreather and they're still below 90%, then that means that all that oxygen that I'm giving them is not going anywhere, right? So their breathing is not adequate enough to bring in that oxygen. So I need to start bagging them. Also, remember, I'm looking for signs of cyanosis, mental status issues, and things like that. All that stuff that we just talked about earlier. Okay. All right. Pulmonary embolisms. Pulmonary embolisms. The cause, this is a blood clot that has formed in a vein, usually in the legs or the pelvis. And that blood clot now breaks off and it circulates throughout the venous system. And remember, the veins bring everything back to the heart. So it's headed back to the heart, goes into the heart, gets kind of pumped through a little bit, and that blood clot lodges itself in the pulmonary circulation. Okay? There's no gas exchange that occurs in the area of that blockage. It's going to cause severe cyanosis to your patient, and it's also going to minimize the return of the blood volume from the pulmonary circulation to the left side of the heart to pump out to the body, right? So it's going to cause, it's going to affect our stroke volume. Pulmonary embolism is a form of obstructive shock. Signs and symptoms from that pulmonary embolism, from that PE, this is going to be a sudden onset of dyspnea, Okay. Most likely sharp chest pain, tachycardia, but their lung sounds, when you listen to their lung sounds, and remember, anyone that has shortness of breath, that's one of the first things you should do after you've cleared ABCs, and they don't have any life threats. Next thing is, I'm going to listen to your lung sounds. Okay. Because if you sit there and you start asking them questions and you get their vitals and all that kind of stuff, and they're wheezing and they're wheezing and they're wheezing, they can deteriorate. So listen to their lung sounds first and then get the rest of your assessment, right? With this patient specifically with pulmonary embolism, they're going to have clear lung sounds. Okay. Initially, when this first happens, they're going to have clear lung sounds. Okay. So that sudden onset of shortness of breath, sharp chest pain, tachycardia, clear lung sounds. They're going to be tachypnic also, right? So they're going to have that increased respiratory rate, and they may have varying degrees of cyanosis depending upon how far into the process of this that they are. Croup versus meningitis versus epiglottitis. Okay. All right. So your croup is inflammation or swelling of the pharynx, larynx, and trachea. This is secondary to an upper respiratory infection. Normally, this is a virus that's been in their body for a while, and it just hasn't gotten any better, right? And so this virus has just progressed. This upper respiratory infection has just progressed. It does have a slow onset. So again, this is something that kind of comes on over a couple of days. Patient has that low-grade fever. Okay, low-grade fever about, I think it's, going to be less than 102, right? And then they have that seal bark cough. Okay, that's kind of the red herring of this, right? The seal bark cough. For your epiglottitis, okay, this is a life-threatening inflammation of the epiglottis from a bacterial infection. So croup is viral, epiglottitis is bacterial. That is different, okay? Because remember, viruses, we just have to, viruses have to kind of run their course, right? But if you have a bacterial infection, then that means you have to get antibiotics, right? There has to be something that attacks that bacteria. So epiglottitis is a life-threatening inflammation of the epiglottis from a bacterial infection. And that epiglottis is the flap that covers the trachea, right? So when we swallow, it protects our trachea and makes sure that food doesn't go down our trachea, food, water, or whatever it is that we're swallowing doesn't go down our trachea. When that epiglottis is extremely swollen, then that means your patient can't swallow. It hurts a lot. Right, so a very, very severe, sore throat, and they can't swallow because it either hurts too much or they physically can't because it's so swollen. And so because of that, they're going to be drooling. Okay, all of the saliva production in their mouth doesn't have anywhere to go. They can't swallow it, so they're going to be drooling. Epiglottitis also has a fast onset. So this is not something that comes on over the course of a couple of days. It comes on quicker, and they'll have a high-grade fever. High-grade. Meningitis is, remember those meninges, right? Which is the tissues that cover the spinal cord and the brain. Meningitis is the inflammation of those tissues. Okay? It can be caused by bacteria, viruses, fungus, parasites. But if you have viral meningitis versus bacterial meningitis is always the worst one, right? But it's the inflammation of those meninges. It's going to cause, it can cause altered mental status, fever. Your patient is going to have some pain in their neck. They're going to have difficulty bending it forward and backwards, okay? So they're going to have a stiff neck. And you might see a petechial rash. Okay, so let me pull that up. A petechial rash. It's kind of like a pinprick looking kind of rash. Okay. That's your petechial rash. Like I said, it's kind of pinprick looking. Okay. Now, when you're thinking about croup versus epiglottitis versus meningitis, a lot of times we see these in kids, okay? Meningitis you can see in adults, absolutely. Epiglottitis you can see in adults. It's just more often in kids, okay? So know the differences between your croup and your epiglottitis, how they present to you, things like that. And then meningitis, what if your kiddo is too young to tell you what's going on, right? They have problems verbally communicating with you, and they really can't tell you what's going on. So look for, if they're kind of tugging at their ears and stuff like that, or if they're super, super young and they still have that fontanelle, right? If they're, I think the fontanelles close up at 18 months. So if they're, super young, below 18 months, and they have a bulging fontanelle without any history of trauma, then it might be meningitis, right? And they have a fever and that kind of stuff, it all leads to meningitis. So just kind of remember some of those signs and symptoms that come off of that. Asthma specifically, we're looking at the patho behind asthma. Asthma is the inflammatory disease of the lower airways, narrowing of those lower airways. So we have bronchoconstriction. There's also air trapping and mucus production, right? And when we have that bronchoconstriction, then we hear wheezing, right? Normally, this inflammation and narrowing of the airways is a result from an exposure to some kind of allergen that causes that to occur. It could be dust, it could be pollen, it could be temperature changes, it could be animal dander. It could be exercise. There's exercise-induced asthma. There's so many different things that can trigger an asthma attack in someone that you just have to get their history, and see what's going on. And again, when they have shortness of breath, listen to their lung sounds, okay? Listen to their lung sounds. Signs and symptoms are going to be wheezing on expiration, right? Wheezing on that exhalation phase, and they're going to have that short inhalation phase and that prolonged exhalation phase because of the air trapping, okay? You might hear wheezing on inhalation as well, but you'll never hear it on inhalation only, all right? Because it starts on exhalation. If you hear inhalation, wheezing, and maybe diminished exhalation, I can see that with an asthma patient, okay? Because if it's diminished, that means they're even tighter and I'm not hearing air, right? But you're going to hear it on exhalation to start with. Treatment for that, we give them albuterol, an albuterol treatment, right? That's our bronchodilator. So they're bronchoconstricted, they need a bronchodilator. So we're going to give them albuterol. It's 2.5 milligrams. We will give it with the nebulizer and our supplemental oxygen. And the nebulizer, we're going to hook up to 6 to 8 liters per minute. Okay. And I want to make sure, let me see here. I don't think we go over COPD in here, so maybe I'll just go over COPD. All right, I'm going to talk about COPD real quick because that goes along with some of our big respiratory issues, okay? COPD, remember, stands for chronic obstructive pulmonary disorder or chronic obstructive pulmonary disease. It's those last words are kind of interchangeable. That's the umbrella term for two separate disease processes in COPD. One is emphysema and one is chronic bronchitis, okay? Your patients that have emphysema, these are our pink puffers, right? These patients have their alveoli are destroyed, or the walls of their alveoli are destroyed. And because of that, those alveoli collapse, and which just disrupts the gas exchange, due to a decreased surface area of the alveoli. Because remember, the alveoli is where the gas exchange occurs, right? So your emphysema patients have loss of surface area in the alveoli from collapse of the alveoli. They also have a loss of elasticity of their lung tissues, which traps the air. It gives them that thin barrel chest appearance, okay? But they are not cyanotic. They don't have a cyanotic look to them like your chronic bronchitis guys do. So that's why we call our emphysema our pink puffers. Emphysema is the most common form of COPD, most likely caused by smoking. That's the most common cause. And so your patient's going to have that smoker's cough. We call it the smoker's cough. It's a very non-productive cough. It sounds like there's something that needs to come out, but it never does. It never does. Again, because of that loss of elasticity, and they're going to have some mucus production and stuff like that, then you might hear some wheezing. Probably going to hear some bronchi. Might have some diminished breath sounds, and they'll have that prolonged exhalation. Okay, so this patient, give them albuterol. That patient is also a good candidate for CPAP, because if their alveoli are collapsed, then if we put them on CPAP and give a little bit more pressure, kind of maintain some pressure, it'll help to keep those alveoli plump and open to help with that gas exchange. Okay. Chronic bronchitis, remember, is your other form of COPD. This is your blue bloaters. Chronic bronchitis, just think about the name, bronchitis. That means inflammation or swelling of the bronchi, right? So chronic bronchitis, chronic means this is going on for a while. This is inflammation, swelling, and thickening of the walls of the bronchi and the bronchioles. It's going to block the airflow to the alveoli, and they have excessive mucus production. These patients are typically overweight. They have a chronic cyanotic appearance to them. Their cough is productive because there's a lot of mucus, and that mucus is able to come up. You're going to hear wheezes, you might hear some crackles, and you might have some bronchi. But those are your blue bloaters, okay? And if they're wheezing, then again, put them on, albuterol, right? So ABCs, airway management, oxygen. If they're wheezing, consider albuterol, consider CPAP for those patients, for those COPD patients. All right, cardiac. Let's shift gears over to cardiac. Okay, so let's do angina. No, okay. All right. So what are the key differences between angina versus an acute MI? Remember, angina and acute MI, they are both chest pain, right? They're both chest discomfort and chest pain. However, the pathophysiology behind what is going on and why the chest pain is present is different. With angina, this is where a portion of the heart needs more blood, needs more oxygen than the coronary arteries can provide at that moment. Okay, so most of the time angina comes on when your patient is exerting themselves, when they're doing some kind of physical activity, because at that moment the heart needs more blood and needs more oxygen than the coronary arteries can provide. And because it normally comes on with some kind of exercise or physical activity, the pain is temporary, because if they stop doing that physical activity, the pain normally subsides. Those cardiac cells are not dying. They are getting enough blood to function, but whatever it is that person is doing at that moment, whether it was, working out or mowing the lawn or whatever, right? Any kind of other physical activity at that moment, they're not getting enough oxygen that they need, because their oxygen demand has increased and they need more. When they stop doing that physical activity, the pain will usually subside. Okay. Normally it resolves within 10 to 15 minutes or something like that. Your acute MI, however, is different, because your acute MI, this is not like a temporary kind of thing. This is actually an occlusion or a blockage, whether it's partial or complete, but it's an occlusion in those coronary arteries that is preventing blood supply from reaching part of the heart. Okay? And when the cells are not getting enough blood, they start to die. So the cells, the cardiac cells, are suffering. Okay? This will not go away with rest. This is not brought on by physical exertion. It can happen with physical exertion, but it's not going to resolve itself when the patient rests. Okay? Or it just happens because at that moment, that occlusion has finally gotten to a point where the muscle tissue is hypoxic, right? So this chest discomfort that lasts much longer than 10 minutes, up to an hour or more, most likely. Does not go away with rest. If you do give your patient nitroglycerin, sometimes it doesn't give them any kind of relief, or it gives them incomplete relief. Okay, but what's going on is the cardiac cells are dying in the area of the heart muscle where the blood flow is obstructed. Okay, so that's the difference between those two. They're both going to have chest pain. They're both going to most likely be diaphoretic and pale and all that kind of stuff. But the questions are, what were you doing when this started? You know, do you have any history? If they've already taken their own nitro and their pain is starting to subside, right? How long has this been going on? All of those questions that we ask is really going to help you kind of key in to what this could be. Is it angina or is it your acute MI? Okay. Congestive heart failure, CHF. So signs and symptoms of CHF. Well, first off, what do we have? What do we have going on? Is this left-sided versus right-sided? Okay. So first off, when you think of the term congestive heart failure, when you just think of congestive heart failure in itself, we think that, the heart is losing its ability to pump effectively and efficiently, and blood backs up. Okay. Now, if you're looking at right-sided versus left-sided, then that's going to show, different areas where the blood backs up. But your signs and symptoms, because when we think of CHF, we just automatically think left-sided, okay? Because the left ventricle, I always say, that's the powerhouse of the heart, and that's the thing that's the chamber that delivers blood to the body, right? That's the workhorse, the powerhouse. That is what is keeping us going here, right? So when you have CHF, the generalized symptoms is shortness of breath. You're going to have edema. We'll talk about where, in a minute, and weakness. The treatment for CHF, if they have that pulmonary edema, fluid in their lungs, and they're still only in respiratory distress, then we can put them on CPAP, right? With supplemental oxygen. If they are in respiratory failure, then I can't use CPAP. I have to bag them. I have to assist those ventilations. Now, if you're looking at, let me see here. Let's go back to your modules. Oh, I'm sorry, home. Let's just go to home. Okay, and pull up your schedule, whatever schedule it is that you have. Pull up your schedule and look at that lookalikes PDF. Okay, definitely take a look at this, all right? CHF versus pneumonia. Here's our right-sided versus left-sided heart failure, okay? So right-sided versus left-sided. Remember, the left side, this is going to be that left ventricle that pumps to the body. The right side, or the right ventricle, pumps to your pulmonary circulation, right? So if you have generalized CHF, which is normally left-sided, then that means they're going to have shortness of breath because the blood and the volume is backing up into the lungs. So they're going to have wet lung sounds with those crackles and rails from pulmonary edema. They'll also have that pink frothy sputum, that blood-tinged fluid, frothy because of the oxygen and the air, that's kind of mixed with it. But that pink frothy sputum that you'll see actually coming up their trachea and out of their mouth, if they're so full to the point that that fluid has to come out that way. Now, if it's right-sided only, then the edema itself, right, the blood is backing up actually into the body. And so the edema is not found in the lungs, it's found in the peripheries, most likely in the lower extremities just due to gravity, okay? Lots of swelling, not just, oh yeah, my feet are swollen a little bit. Oh, my ankles are a little bit swollen because I've been on my feet all day. Not something like that. We're talking like, this is a lot, basically where if you were to, push your fingers, I know this is going to sound weird, but if you were to push your fingers into their swelling, we call it pitting edema. Look at that. And it just kind of stays indented. That's a lot of fluid. That is a lot of excess fluid. And most of the time means there's something wrong. Okay? Most of the time, look at that. That's just crazy, right? So we really start to worry about when your patient has that pitting edema. Okay, so you've got normal, mild, moderate to severe, and you do have different stages of it. This is not necessarily something that, well, that's not a good, it's kind of blurry. But you do have different stages where, depending upon how long it takes for that that indentation, that pit that you form, how long it takes to kind of come back to normal is, basically the stage, right? So if you have stage 1 pitting edema, it's not that much. It kind of just goes back to normal pretty quickly. Number 2, it's a little bit deeper. It takes a couple seconds, all the way up to, it can take over, 20 seconds or more to refill, basically. But your pitting edema with that peripheral edema, not pulmonary, but peripheral edema from your right-sided heart failure. So the treatment is going to be different for your left-sided versus your right. If your patient says, I've got congestive heart failure and they're having shortness of breath, then listen to those lung sounds. You hear those crackles and rails. Sit them upright, put them on CPAP with high flow O2 transport, right? If your patient only is experiencing right-sided, and sometimes they don't even know, right? Sometimes this might be like a new onset and they're not sure that they even have congestive heart failure. But if you've got someone who says, yeah, I've got a lot of swelling going on, I'm really not sure. Well, it's very possible they have right-sided congestive heart failure. You don't put that person on CPAP because their lungs are clear, right? They have clear lung sounds. So this is just more recognizing the possibility that this is what's going on and getting them to the hospital, okay? Your CHF patient will most likely not have chest pain, okay? Even though this is a cardiac related issue, chest pain is not the primary symptom of this, okay? It's more shortness of breath. Okay. So treatment for CHF, we already talked about this. Put them on CPAP if they're still only in respiratory distress and they have good control on their airway. And adequate ventilations and tidal volume and all that good stuff. But if they're in respiratory distress, then go ahead and bag them, okay? Beck's triad. So another cardiac related thing, okay? Beck's triad. This is signs and symptoms of cardiac tamponade. And the signs and symptoms, it's a triad, so there's 3 things. You're going to have your narrowing pulse pressures, your muffled heart tones, and your JVD, or your jugular vein distension, right? And remember, your narrowing pulse pressures, that's when your systolic and your diastolic, the numbers are getting closer together, because Beck's triad, or your cardiac tamponade, is a form of obstructive shock, okay? Beck's triad is when you have the fluid surrounding the heart in that pericardial sac. Cardiac tamponade and pericardial tamponade has that fluid in that pericardial sac, and that fluid is compressing the heart and keeping it from filling so it can contract a good normal stroke volume. So it's decreasing the stroke volume. When that occurs, your systolic and your diastolic blood pressures are very close to one another. Very close to one another. And so that's why we have those narrowing of the pulse pressures. Muffled heart tones, if you were to try to auscultate heart tones, it's going to be muffled and really kind of hard to hear. And then, of course, because the heart is being compressed, then the blood is not moving forward as well as it should, and so it's kind of backing up. And if it's backing up into the body, as it would with cardiac tamponade, you see jugular vein distension. So it's extremely important to do that head to toe. Really look at that neck and make sure that you're not having any JVD, right? So Beck's triad, make sure you're good with that, cardiac tamponade. What's the formula for cardiac output? Cardiac output is CO is your heart rate times your stroke volume, okay? Stroke volume times the heart rate. Anything that affects the stroke volume, and that's going to be anything shock related, will affect your cardiac output and eventually affect your perfusion, which is why we have the increase in heart rate, right? But we'll get on that in when we talk more about shock. So make sure you know your formula and you understand it. The diastolic blood pressure versus your systolic. The diastolic, remember, that's the relaxation or the period of relaxation of the heart, especially of the ventricles. And the systolic is the contraction or the period of contraction of the heart with those ventricles, right? The ventricular contraction and the diastolic. Ventricular contraction is the systolic and the diastolic is the ventricular relaxation, okay? And those pressures that we get, those are the pressures that's residing in the arteries during that time of either relaxation or contraction, okay? We already talked about right-sided versus left-sided. Go ahead and make sure that you're good, good with that. Look at that lookalikes PDF. That'll really help you, okay? Really help you when we're going through all of that. What is the chronological order of treatment for a pulseless patient? Okay, so this is BLS, right? You have, hey, are you okay? All right, they're unconscious, they're unresponsive, feeling for pulses, no breathing. All right, start compressions. Chest compressions always comes first. Then you apply the AED, and then you can put the pulse ox on them, okay? I've got to get on the chest and start providing those chest compressions as soon as possible. So if we were to look at these numbers, it would be 1, 3, 2. Chest compressions is first, apply AED is second, pulse ox is third. Okay. This is straight off of this next question is straight off of your Mod 1 exam review, right? Where we follow the drop of blood through the heart. So make sure you're good with that, okay? Your superior vena cava, remember, is what brings blood back to the heart from the upper body, from your upper extremities and your upper body. The inferior vena cava is what brings blood back to the heart from your lower extremities, from your torso and from your lower extremities. They both will meet in the right atrium. So the numbers here, we've got superior, inferior vena cava, that's 1. Right atrium is 2. It goes through into your right ventricle. So that's 3. Then it's going to go through your pulmonary artery into your pulmonary circulation to get oxygenated. So pulmonary artery is 4. Brought back to the left side of the heart with your pulmonary vein. So pulmonary veins is 5. Goes into the left atrium is 6. Goes into the left ventricle, which is 7. And then pumps into the body through the aorta, which is 8. Okay, so the actual order here, if we were looking, would be 1, 7, 2, 4, 3, 6, 5, and 8. So make sure that you're good with following that drop of blood through the heart, because it's so important to know that, and that will help, especially when we talk about when something's not working appropriately. Where does that blood back up into, right? How does that work? The electrical pathways of the heart, what order it conducts. So this is not necessarily something that, you guys are going to be dealing with on a regular basis, but it is important to actually just to know the knowledge of this. And I think that's why this is on your exam. But let's just take a look real quick at the electrical conduction, because we've gone over so many times that following the pathway of the blood, but how does the heart actually pump, right? And once you get into if you go to paramedic school or med school and you start your cardiology and all that kind of stuff, this is how we know the shape of the EKG, right? And you guys have, helped with the EKGs and all that stuff in your clinicals, putting those electrodes on your patient's chest. This is how we get the appropriate tracing to see what's going on. So if you look at, let's see, this is probably the best one. Okay. So you have these different nodes. This first one is your SA node or your sinoatrial node. Then you have what's called an AV node or your atrioventricular node. And then you've got your Purkinje fibers, okay? Now the SA node, this is what we call the pacemaker of the heart. And this is what is going to help keep us in between 60 and 100 beats per minute, because that's the normal heart rate of an adult, right? And basically, this is going to just start the contraction, start the cells of contracting. Okay, and this electricity is going to go through both the atriums, and then it's going to go into each ventricle. And so, your heart, when it pumps, it doesn't pump all together. Your atrium and your ventricles are a little off from one another because remember, it has to go from the atrium into the ventricle and then from the ventricle out. So these guys kind of pump first, and then these are right behind it. Okay, but they have to be like stimulated to do that, if you want to think of it that way. Okay, because the electricity, the stimulation has to go in that order. So you've got your sinoatrial node that starts here. If this guy fails, which sometimes happens, you have this guy, he's your backup. He's your atrioventricular node because it moves from here to here and then down into your ventricles. If this guy fails, which again happens sometimes, then your ventricles will take over. They know, your heart muscle knows that it has to beat. Your heart is is literally the only muscle in your body that knows that it has to do something without being told, right? Your brain has to tell your body to do everything. Whether it's from, your higher level of thinking with your skeletal muscle, your voluntary movements, to your brain stem is talking about, breathing and all that kind of stuff. But your heart, your cardiac muscle does not have to be told what to do. Okay, it has these electrical potentials across each cellular membrane, and it will work on its own. That's why there's so many times that you might see someone who is, we say they're brain dead, right? Their brain isn't giving, messages to their body, but their heart is beating on its own, and it's totally fine. But that person who doesn't have any electrical signals in their brain, they have to be on a ventilator in order to breathe. But their heart is still beating. Nothing is telling their heart to beat. It knows that it has to. So just kind of keep that in mind. It starts at the SA node, goes to the AV node, and then it goes through these Purkinje fibers. And the Purkinje fibers are all in the muscle of your ventricles. Okay, so that's what keeps your heart going. And when you have someone who has a pacemaker or something like that, it's because the electrical conduction system is not working appropriately, and so they need a little zap, a little jolt that kind of gets it going. It's an artificial, electrical conduction pathway that starts. So, patients who have irregular heartbeats or heart blocks, things like that, things that you'll learn, like I said, later in cardiology or something like that, then they will have irregular heartbeats and skipping beats and extra beats and all that kind of stuff. So it's really kind of cool, but it's not something that you absolutely have to know for EMT. It's just good to know. All right, OB-GYN, newborn patients, that kind of stuff, okay? All right, following anatomy, what's the purpose of that anatomy? So the uterus, of course, the uterus is one of the most important things, right? Because that's where the baby grows. So the uterus is the pear-shaped hollow organ with muscular walls where the fertilized egg will attach and develop throughout pregnancy. If the egg is not fertilized, remember, then the egg will be disposed of with the excess tissue that's been building up over the last 28 days. It will be shed during your patient's menstrual cycle, right? But the uterus itself, this is where we want that fertilized egg to attach. And this is the hollow organ that will grow with the fetus as it develops throughout pregnancy. The umbilical cord, super important, because the umbilical cord is what connects the mother and the fetus through the placenta, right? It's going to help deliver with the delivery of oxygen, nutrition, and the removal of waste. All of that relies upon this connection. In this umbilical cord, it's very vascular. You have two arteries and one vein. Okay, so very, very vascular, which is why once the kiddo is out, we always have to clamp that cord before we cut it. Okay, very, very vascular. The amniotic sac and the fluid. The amniotic sac is the fluid-filled bag-like membrane where the fetus will develop, right? The fluid itself, there's anywhere from 500 to 1,000 milliliters of amniotic fluid, so anywhere from half a liter to a liter of fluid, and this helps to we have this in there because it helps to insulate and protect the fetus as it grows. Okay. So it's kind of floating and insulating it and all that good stuff, okay? The sac will normally rupture at the start of labor. However, sometimes it doesn't, right? We've talked about that in Mod 4. If there's an intact amniotic sac, then that means you will have to break it. The fallopian tubes. The fallopian tubes, these are the tubes that connect the uterus or connect with the uterus. It kind of it is the pathway between the ovary. So when the ovary releases the egg approximately every 28 days, it releases an egg, and the ovum or the egg cell will travel through that fallopian tube into the uterus. Okay. If fertilization occurs, fertilization normally occurs in that fallopian tube. And then remember that fallopian tube is also the most common place for a fertilized egg to attach when you have a patient with an ectopic pregnancy, right? We want that fertilized egg, however, to continue on and implant itself in the uterus for a normal, healthy pregnancy. The ovaries themselves, these we have two, right? Your female patients have two, one on the left side, one on the right side, okay? In the left lower quadrant and the right lower quadrant. These organs produce the female sex hormones and the specialized cells for reproduction. Okay, and like I said, it will release an egg approximately every 28 days. Okay, now if you have patients who have histories of twins and triplets and multiple kiddos, then their ovaries might be more prone to release more than one egg every 28 days, which is where we get possibility of twins. Okay. What are the key differences between preeclampsia versus eclampsia? Vital signs do you expect and all that stuff. Okay, so preeclampsia, remember, this is your pregnancy-induced high blood pressure. Pregnancy-induced high blood pressure, what's normally above 140/90. Okay, your patient will have protein in their urine, and the reason why I say this is because if they have been getting what's the word I'm looking for? Prenatal care with a physician. Every time that expectant mother goes in to see their OB doc, they always have to leave a urine sample, and that doctor is looking for protein and glucose in their urine, right? If there's protein in their urine, then there's a problem with possible preeclampsia. If there's glucose in their urine, then that means they have gestational diabetes, right? So this is a constant assessment. But what we're looking for, okay, because we don't have urine analysis and all that good stuff, we don't do that. But what we're looking for is your patient's going to have headaches, blurry vision, right? Generalized swelling of the face and the hands, legs and the feet, lots of swelling that comes on like in the course of a day or two. I was fine yesterday and all of a sudden my face is all swollen and my head hurts and I've got blurry vision and things like that. They could possibly have altered mental status as well. And it's caused by this blood pressure, this increase in blood pressure. Now, eclampsia is when you have all of those same signs and symptoms as preeclampsia, but now your patient has developed seizures. So if you have a patient who's experiencing all the signs and symptoms of preeclampsia, we worry that seizures will occur, right? I mean, she's already preeclamptic. We got to get her to the hospital, but we don't want seizures to occur. Now, there's no way to stop it, but if it does occur, then you have to, suction the airway, ventilate, and just take care of your patient as a seizure patient, right? What trimester do we see this in? Normally that third trimester. Preeclampsia and eclampsia we normally see in the third trimester. All right, your APGAR. Just like your GCS earlier, you've got to know what your APGAR is and how to calculate it, okay? Remember, APGAR stands for appearance, pulse, grimace, activity, and respirations. So please go over that, okay? Let's see here. Please go over that APGAR score. Pull this up. I can't remember which one I used last time, but this one looks pretty good, right? And your scores are going to be 0 up to 10. Remember, your APGAR score is your assessment of the newborn. We do it at 1 minute postpartum and then 5 minutes postpartum. The appearance, they're either cyanotic all over, pink in the core with cyanotic extremities, or pink all over. Okay, and that's going to be 0, 1, 2. Pulse. If they don't have any pulses, it's 0. If their pulse is less than 100 beats per minute, it's 1. If their pulse is over 100, then the score is 2. Grimace. Grimace is how are they, what's their facial expressions, right? How are they responding to us in that way? If they're no response to any kind of stimulation, then that's 0. If they're have kind of like a feeble or weak cry when they're stimulated, that's a 1. And then if they're coughing and crying vigorously and really doing well, pulling away and very active, then that's 2. Again, activity, no movement. If they're limp or flaccid, then that's 0. If they have a weak movement, weakly moving their arms and stuff like that. And remember, when we want to, when we have a newborn, these kiddos are, we're messing with their arms and legs. We're trying to dry them off. We're trying to do all that kind of stuff. And if they're actively kind of like resisting us moving their arms and legs, then that's what we're looking at with activity. So they've got active movement and actively moving, moving. If they have a weak response to us, stimulating them, or if there's no response. And then respirations, they either have nothing, weak or irregular or slow breathing, or they have that good, strong cry, okay? So make sure you know your APGAR score. Very important to know your APGAR score. Key differences between your ectopic pregnancy and your miscarriage. So, excuse me. First off, both of these are going to be found in the first trimester, okay? Ectopic pregnancy is first trimester emergency, and a miscarriage is considered a spontaneous abortion that occurs before 20 weeks gestation. Okay, so it's the loss of pregnancy prior to 20 weeks of gestation without any medical intervention. So this is not the intended abortion, right, where you go to have this done. This is a spontaneous abortion, which is the miscarriage, okay? The key differences in this, there will be vaginal bleeding. There will be a lot of abdominal cramping in that patient who's experiencing the miscarriage. That vaginal bleeding is going to be a lot because the body is aborting the fetus. The body is getting rid of it, right? So depending upon how far along in the pregnancy your patient is going to be how much tissue is passed, right? Because it may not be just blood, it may be actual tissue, which is, oh gosh, what's the word I'm looking for? Anyway, it might be actual fetal tissue that's passed. The ectopic pregnancy, also remember, this is first trimester. Both of these are first trimester, but your ectopic pregnancy, normally your patient doesn't know she's pregnant. Okay, I mean, she might, but this is going to be, remember, very specific. This is when the fertilized egg attaches itself outside of the uterus and starts to develop outside of the uterus. Normally, this happens in the fallopian tube, and that fallopian tube does not flex, doesn't grow. So as that embryo starts to grow, it puts pressure on that fallopian tube. Your patient's going to experience abdominal pain. Okay, so severe abdominal pain, sudden onset of abdominal pain. There may be vaginal bleeding. There may not, or there may not be a lot. But if your patient has a ruptured ectopic pregnancy, remember she's going to have signs of shock. So this is early on in pregnancy. She may not even know she's pregnant yet. Abdominal pain, sudden onset of abdominal pain, some vaginal bleeding, signs of shock. Okay. When you have an OB call, what are some things that make us think of stay versus play, or stay on scene versus transport? Okay, so stay and play. This is going to be, delivery is imminent, right? So this is when your patient's mother says, or the mother says she feels the need to push. Maybe she feels the need to have a bowel movement, because remember, when she needs to have that bowel movement, it's because the baby's head is dropped into the birth canal. Okay, and we're well into our phases of labor at that point. Even if she says, she's about to deliver, the baby's coming, something like that, or if you do a quick look and you see crowning. All of those are key things for you to say, all right, we're not going anywhere. We're having this baby right here on the scene, and then we can transport. Low and go situations, when we're not delivering on scene. Okay. Very specific would be like your breech presentation with the head still stuck inside. If the head is still stuck and won't progress. If there's a limb presentation, okay, so you have an arm sticking out or a leg sticking out, or the prolapse cord where the cord is sticking out first. If you have a breech presentation where the body is out and the head is still stuck and you cannot get that head out, then we got to go, right? We got to go to the hospital. You want to insert your hand into the vagina, form that V on the fetus's face, because if their body is out, then that means that they're starting to breathe, right? And we need to create an airway. That limb presentation tells you that the baby is not in the appropriate position to be born through a vaginal delivery, and it's gonna be bad, right? Because it's gonna delay your baby. The fetus is most likely gonna have some kind of hypoxic brain injury from a delay in the birthing process. Mom's going to have an extreme amount of trauma because the baby is not placed correctly. It's not positioned correctly to come out easily. So a limb presentation is elevate mom's hips, put some a moist sterile dressing over the presenting limb and get going, right? And then the prolapse cord, remember the prolapse cord is where that cord comes out first. And the concern at that point is that the baby's head or the fetus's head is compressing the cord within the birth canal. So we elevate mom's hips, we insert our hand into the vagina to make sure that we get the pressure of the baby's head off the cord, and we rapid transport. Okay. How do we position a pregnant woman on the stretcher and why? We put her in what we call that left lateral recumbent position. We do not want her lying supine, especially in the third trimester, right? Because this supine maternal hypotension that happens is in the third trimester when that fetus is really large. If we put her supine, the weight of the fetus will sit on that vena cava and impedes blood return to the heart, reduces that preload, and your patient's going to feel real dizzy and wants to pass out and all that kind of stuff. So we put her on her left side. All right, we just talked about the 2 times that you insert your fingers into the vagina during delivery. Okay, and that's going to be, remember, your prolapse cord, where the cord is presenting first. You put mom in a hips elevated position. You elevate her hips. You place your sterile gloves, your sterile gloved hand into the vagina to keep the fetus's head off the cord, and then rapid transport. Keep your hand in there, okay? Because as soon as you let go, the head will compress the cord again, and now the fetus doesn't have any blood flow or oxygen, right? The breech birth is where the butt and the body has delivered. But the problem with this is if the head is still stuck inside, just like we said before. So when you're talking about the prolapse cord, let me go back to the prolapse cord. The body, the entire body of the fetus is still inside. The kiddo's not breathing on their own. So they're still relying upon the oxygen delivery from the umbilical cord, right? Which is why we have to get the pressure of the head off the cord. But in a breech birth, where the body, the legs and the body and everything has delivered except the head, you're holding the body of the baby, of the newborn, right? You're holding them. And just by holding them, you're stimulating them. And they're going to try to breathe. Plus, because their body is now outside of the birth canal, they're able to expand their lungs. So they're going to try to breathe. But unfortunately, when the head is still stuck inside the birth canal, that's our problem. So this is when you would form a V with your gloved hand, again, sterile gloves. Insert your hand into the vagina, find the face of the baby, and have that V on the face of the baby, kind of creating an airway, an airway channel from the outside air. So when they do breathe, they're actually able to breathe air itself, okay? Instead of having their face compressed up against the side of the birth canal. So make sure you're good with all of your pregnancy-related emergencies.